In interventional radiology, we use imaging technology to guide minimally invasive procedures. In kidney cancer, IR offers targeted treatments such as ablations or embolizations that directly address tumors without traditional surgery. These procedures help patients avoid these major surgeries with minimizing the recovery time and focusing on the treatment on the tumor sites alone. In interventional radiology, we can play different role across multiple stages. In the early stage of kidney cancer, we use techniques like cryoablation, radiofrequency, or microwave ablation to destroy small tumors. In the intermediate stage, particularly when the cancer is confined to the kidney, sometimes embolization and ablation can be effective for tumors that surgery cannot easily reach. And then finally, for the advanced stage, IR helps manage essentially the symptoms and complications, such as the blockage of blood flow of the tumor and treating bleeding, as well as pain management. In the metastatic disease, IR can help also target all the metastatic sites in order either to maximize the treatment of systemic therapies or also to control the disease in certain organs. In big centers or cancer centers, interventional radiologists are part of the discussion every time in tumor boards. They weigh in on different decisions, especially from the diagnostic part. So we are involved from the start with the biopsy. Most of the patient require tissue sampling before undergoing any kind of treatment. So this is the first part of the involvement of an interventional radiologist. Then the interventional radiologist can be consulted down the road if there is some resistance to systemic treatment or if there is like pain that needs to be addressed or some complications from traditional treatments where interventional radiologists can help alleviate pain or fix the issues. As I work in a big cancer center, we have partnership with community hospitals. So we have referral from oncologists for certain procedures. So they transit through our partnership program. We see these patients in clinic. We address the concern. Sometimes we need to discuss their cases in a tumor board to allow them to have the best treatment. Then once the treatment is done, they return back to their community hospital where they have their follow-up. So in regard of where to find this interventional radiologist, so experience is the key, especially in kidney cancer. Look for IRs who specialize in oncology and work in high volume centers with access to advanced images and collaborative cancer teams. Credentials as well are very important. So board certified interventional radiologist with also affiliation to cancer center is important indicator of expertise. Because of the intervention being mini invasive, so we can achieve excellent local control with low morbidity. So there is no need to stop systemic treatments as for a surgery. We can preserve the enrollment for clinical trials for many of these patients because we're mini invasive. We control only the disease that is not responding to the treatments. So the patients, they are on their maintenance treatment. They come for pinpoint lesion that escaped the treatment. So this is like the perfect setting for these patients. In ablation procedure, we place small needles inside the tumor to generally destroy it using either thermal or non-thermal energies. For the thermal energies, we have either radiofrequency and microwave, which uses heat, and cryoablation that uses cold to destroy the tumor. In an IR procedure, first we need the image modalities. So we use either CAT scan, MRI, or ultrasound to guide our procedures. The tools we use are probes looking like needles that's going to be inserted percutaneously or using this image guidance. So we either have this cryo probe that's going to use to freeze the tumor, or other probes that use heat like microwave or radio frequency. We consider factors like tumor size, location, patient health, and specific goals of care. For instance, during cryoablation, we use it for tumors near vital structure because it minimizes damage to surrounding tissue. Heat-based technology are for smaller lesions that are in safe locations used for a faster treatment. For small lesions, now studies have shown that for this localized kidney tumor, ablation has survival rates comparable to surgery with fewer complications. The choice depends on individual circumstance and can be discussed with patients that need same-day procedure with minimal pain, quick return to work, and flexibility in regard of sedation. Surgery are reserved for patients mostly who are fit and can tolerate bigger anesthesia and also have pretty good health to support heavy surgery.